Good afternoon, everyone. We're so excited to have Dr. Tony Rosen with us this afternoon to present on the key role for emergency room departments, hospitals in elder abuse identification as well as response. Dr. Rosen is a researcher in elder abuse and geriatric injury prevention at Weill Cornell Medical College and is a practicing emergency physician at New York Presbyterian Hospital. Dr. Rosen's research focuses on improving identification, intervention, and prevention of elder abuse in emergency departments and other healthcare settings. His research has explored forensic injury patterns in physical abuse, identifying specific clinically detectable differences between unintentional injuries and those from abuse. Dr. Rosen completed his residency training in emergency medicine in 2014 at New York Presbyterian Hospital and has completed a geriatric emergency medicine fellowship at Weill Cornell in 2016. He received his MD from Weill Cornell Medical College and his MPH in epidemiology from UCLA. If you want to see Dr. Rosen's full biography, you can see that in the session notes. So without further ado, I am thrilled to introduce Dr. Tony Rosen and take it away.
Thanks very much. Hopefully you can hear me. As Laura said, Laura, thank you for introducing me, and thank you to David Burns for inviting me, and for Rianne, and for the entire Elder Abuse Ontario team. I'm a New Yorker, as you heard, and so I am going to unfortunately probably make it very challenging for our ALS colleagues. I am right now talking at about a third or even a quarter of my regular speed. And so I apologize in advance, both to you and particularly to our ASL colleagues. But it's an honor to be here. And I hope that the work that I'm going to discuss will be helpful as part of this really exciting conference. So first, from my perspective, one of the big challenges in elder abuse response is that, and I suspect it is similar in Ontario to the way it is in New York and in most other communities, at least in the United States, which is that there are some really wonderful community-based programs and community-based services, and it's almost as if there's a big wall between those services and the work that they do and the hospital. It's as if the hospital and emergency department really just don't talk very effectively to these community-based services, and that these community-based services have difficulty talking effectively to the emergency department and hospital. And so one of the things, or rather the main focus of my conversation today, is can we do a better job of connecting these two groups? And particularly, can we essentially identify the real potential and find a way to fulfill the real potential of the ED and hospital, or rather the emerge department, as we say in Canada, or hospital and hospital, with the important services that I think many of you that are hearing this provide to older adults who are vulnerable in Ontario and other places. So first, I'm an ER doc. And so I like to point out that the ED and hospital is an important opportunity to identify elder mistreatment and to initiate intervention. After all, evaluation by a healthcare provider may be the only time that an abused or neglected older adult ever leaves their home or the institution in where they live. Also, I'm an ER guy. Abuse victims are less likely to see a primary care provider in the community. The limited research that we have suggests this, and are more likely to present to an emerge department. Also, emerge departments and hospitals typically manage acute injuries and illnesses So if you present to your regular doctor with a broken arm or with an exacerbation of your congestive heart failure, they're going to turn around and send you right to the emergency department. Also, if you think about it, EDs and hospitals may be an ideal place to intervene or to identify and intervene. After all, we have varied disciplines observing a patient, not just the doctor, but the nurse, the technologist, the transporter, the radiology tech, the registration team, lots of different eyeballs. Additionally, and it may be better in Canada than it is in the US, but the evaluation for us is typically prolonged, no matter what we do. Additionally, if you think about it, an ED in hospital has lots of resources, and those resources are available 24 hours a day, 7 days a week. And even in New York City, at 3 a.m. on Sunday morning, the only place open is the emergency department. Despite this, it turns out that research that colleagues and myself and others have done, and also an examination of our own practice here in New York in our emergency department, suggests that ED and hospital providers almost never identify or report elder abuse. And there are a lot of reasons for this, and I know I don't want to overburden my ASL interpretation colleague, and also you can read the slide, but I want to highlight a few. They are in the categories of environmental, the provider themselves, and the difficulty and complexity of these cases. All of these things are things that we're trying to work on with our research and with our clinical practice. But what I'm going to focus on here are the top two, because I think they are the most important ones. And I think they're the ones that are most relevant for us to try to fix. One, lack of time to conduct a thorough evaluation. Turns out the ER is busy. Also, the absence of a protocol for a streamlined response. So, you identified a problem. Now what? So I want to highlight for you briefly what I think is different about specifically emergency medicine than other types of doctors or medical providers. It turns out that I'm an ER guy, and I provide care for multiple, let's say 15 acutely ill or injured patients at the same time. Not one at a time, but at the same time. And if you think about it, my time is a limited resource. And so any time that I spend caring for one patient, talking to one patient, providing specific focus on one patient is necessarily time that I'm not spending with the other 14 patients. And so if you think about it, I'm the guy, unfortunately, and I apologize in advance, but I'm the guy that wrote the textbook chapter that said, you've got to separate the older adult and you've got to ask them questions to see whether this was in fact a fall or whether they feel safe at home and whether there are any concerns and whether their needs are being met. But if I do that and I find potential abuse or neglect, well, that's going to require more work, more phone calls, more assessment, more follow-up. And oh, by the way, in the ER, there's always a bus accident that's just waiting to send in 15 more patients. And so if you think about it, the ER doctor might think, do we really want to know? The provider is almost disincentivized with additional work and longer time to disposition if they suspect or take the time to assess for mistreatment. And so what sometimes happens is, well, they say their elbow hurts. Let's get an elbow x-ray and get them out of here. I got lots of other patients. It turns out, though, a better model exists. Child protection teams. We have them in every emergency department that I've ever worked in. And they've been around for more than 50 years. These are ED and hospital-based. I say ED frequently. Emerge department, multidisciplinary teams that intervene for child abuse victims. And it's typically activated by the ER by a single phone call, or if you like, an easy button. I'm concerned that this fall off the monkey bars is not actually a fall off the monkey bars. Again, I feel like many of you that are on this conference also either work in child protection or have in your career and are certainly familiar with that conundrum. So essentially, if you are concerned about a child, you call the team or you activate the team. And these team members who are specialized work collaboratively. They involve other resources, the authorities. They involve probably some of you who are on this presentation, and also attractive to us in the emergency department. It allows emerge providers to return to the care of other patients, the heart attacks and strokes and car accidents that we are supposedly trained to do, with the team, the expert team, advising us about the next steps in care. As I mentioned, these have existed for 50 years or more and are certainly present in most large US and I suspect large Canadian institutions as well. Certainly, there's one in Sick Kids in Toronto. Despite this, when we started our work, we knew of no equivalent or analogous elder protection team. No protection team for older adults that was ED or hospital-based. So we created one. We call it the Vulnerable Elder Protection Team. And it's a consultation service available 24 hours a day, 7 days a week, because that's when the ER is open. That's when the hospital is open, to assess, treat, and ensure the safety of elder abuse and neglect victims, while also collecting evidence when appropriate and working closely with the authorities. We were hoping, and we've found, and I'll talk about that in a moment, that it increases identification and reporting of elder abuse because it's easier if all you need to do is press a button, but simultaneously decreases the burden on emerge providers because the team takes care of the challenging work to figure out appropriate next steps. So again, similar to or borrowed from or even stolen from child protection teams. Initially, we conducted focus groups of stakeholders at our hospital, focus groups from many different professional disciplines. And here's what they told us. Yep, an ED-based consultation service would be utilized and would help. They highlighted, and this should come as no surprise to this group, but they highlighted the importance of social workers and care coordination and emphasized that coordinating with inpatient and outpatient medical and service providers would be critical. And they identified challenges for this service. And we actually published the findings from these focus groups. Then we prepared. We trained 400 plus ED and hospital providers. We gave social work grand rounds. We met we presented at the hospital ethics committee meeting, and then I had to join the hospital ethics committee. We also created an online module for ED nursing and administrators on how to interact with our team and how to recognize abuse. We developed comprehensive written protocols, procedures, and guidelines, all of which we have published and posted. And we designed standardized documentation templates and an on-call schedule. I'm actually on call right now, which is a bummer, but it's okay. I share the call with 4 other colleagues. So I've been on call for the last 4 days. I'm on call until 7 tomorrow morning, 7:30 tomorrow morning. We launched on the 3rd of April, 2017. So now 5 years ago, 5.5 years ago. But actually, we got our first consultation 2 days before they called us. I'm glad I brought the pager home because we actually got our first consultation before we even opened. So what do? Well, we have a medical provider on call 24/7 to consult and assess and offer assistance to other medical providers, offer assistance via telephone. I last did this on Saturday evening, either on telephone or in person. Depending on need, we evaluate the older adult face-to-face. I may be going today. And what does this medical provider do? Well, we assess the likelihood of victimization by each type of mistreatment. Is this person suffering from neglect? Is this person likely suffering from financial exploitation? Based on what we know, we conduct a forensic evaluation, including for sexual assault abuse if appropriate, with comprehensive documentation and photographs. I suspect that there may be some folks from criminal justice in this meeting, and I'm sure that you've been frustrated by the medical charts that simply don't describe in enough detail the information that's critical to obtain justice for these older adults. We evaluate whether the victim is in immediate danger and whether interventions to ensure their safety are appropriate, whether that involves security, changing their name, restricting visitors, all things that we can do in the hospital much more easily, of course, than can be done in the community. We provide support to victims during this crisis, and we advise the ED and hospital primary medical team about next steps from an elder mistreatment perspective. But again, I'm an ER doctor. It turns out that social workers are way more important. They're the heart of our program. We actually have 2 specialized social workers. One of them sits right next to me, although she stepped away from her desk. I'll show you her in a few minutes when she returns. But these are social workers who are specialized in this area. They've done additional training, and they've become expert by working in this area. I'll introduce Alyssa Ellman is now returned. That's Alyssa Ellman. She's one of our social workers, one of our expert social workers, actually joined our program before it started. So she's been with us since the beginning. They obtain collateral from work and work with family members, caregivers, primary care providers, and other concerned persons. They involve PD, or the police department, or adult protective services, which of course is a US approach to adult protection as appropriate. They coordinate with the primary medical team and resources from the hospital, including psychiatry, patient services, the ethics committee, and security. They identify which community-based services may be appropriate to offer the victim, or the survivor, I should say. And they collaborate with community-based organizations, including the New York City Elder Abuse Center, on challenging cases. And these cases can be challenging. Interestingly, we have lots of hospital-based social workers, and even ones that have been doing this for 20 years, defer to Alyssa and her colleague Elaine, because there's a lot of specialized knowledge that they just don't have. And that's something that we think is really exciting, because we can provide this to older adults. That having been said, Alyssa, and I'll show her to you again, Alyssa likes to say that she thinks she might be teaching herself out of a job, because now, several years later, many of our social work hospital-based colleagues are like, Alyssa, I want to report this case to you. I've already done this, and this. All things that they probably wouldn't have known to do a couple of years ago, but now they almost pre-anticipate, that's not a word, but they anticipate what Alyssa is going to recommend. And so we're hopefully train the trainering in a way such that more folks know what's out there and how they can be helpful. So what does our program do? Well, we do lots of different things, and I'm going to show you a few of them and talk about some. But we do a capacity evaluation, or we have our psychiatry colleagues help with a capacity evaluation. It turns out in our work, and I suspect that this occurs also in the work that you do, it's common that our older adult patients will say, yeah, you're right. My son has been withholding food. He isn't providing good care, and he stole my pain medication, and I think he sold it. But I love my son, and I want to go home. And I know it's not safe because he threatened me, but I don't want to be admitted to the hospital. That can be really challenging. It can be challenging to know whether that older adult has capacity. And I want to pause to explain at least how we do it in the States. An 8-year-old comes to me and says, Dr. Rosen, you're right. My mom didn't give me dinner. She locked me in my room. This bruise is not from a fall off the monkey bars. She hit me. But I love my mom, and I love my room, and I want to go home. We say, sorry. We can't let you go home as a society until we've decided it's safe. But then when that same person comes back, and they sometimes do at age 26 or 28, and says, you know, Dr. Rosen, this injury is not because I'm clumsy. This is my partner. He hit me in the belly several times and threatened me with a knife. But I love him. And he told me he was going to change. And I want to go home. We say, we're open 24 hours a day, 7 days a week. Here are the resources. We want you to know that this violence can escalate and can be life-threatening, but you have a right to make this decision. I care for plenty of 98-year-olds who can absolutely make this decision to leave against medical advice. And I care for plenty of 71-year-olds who can't. And I care for folks who maybe could 12 months ago, or maybe could a week ago, or even an hour ago, and now can't. And so understanding capacity, we certainly do not want to hold someone who has the capacity to make their own decisions against their will, but also we want to protect someone who doesn't have the capacity to make their own decisions. As I said, it's challenging. We determine acute security needs. We do a comprehensive social evaluation, as I mentioned. Alyssa and her colleague Elaine are critical. We notify patient services. This is in our hospital, our pathway to ethics and legal. And again, it's really nice that a hospital has an ethics and legal team. One of the things that we often see, and again, I'm not sure exactly how it works in Ontario, but in New York State, we have what's called a healthcare proxy law. So I can designate anyone. Mine is my wife, but I could designate my parents. I could designate Alyssa. I could designate a friend. And I would sign papers, and that person would be responsible to make healthcare decisions if I was unable to do so. We also in New York State have a healthcare surrogacy law. And the surrogacy law is in the not that unlikely event when someone does not have a healthcare proxy and is unable to make their decisions. And in the United States, it begins with spouse, and then then parents, and then adult children in birth order. So again, in order to resolve conflicts, there is a surrogacy law. However, in elder mistreatment, the healthcare proxy or the healthcare surrogate, if there is no proxy, is sometimes, in fact, often the person standing next to the patient telling us what they think we should do. And we're not sure whether we should be listening. And so that's why we involve ethics and legal in these cases, which can be very challenging. We also report, as I mentioned, to Adult Protective Services, which is something that is in the States, the police, which I know you guys have up in Canada as well, and multi-disciplinary teams, which I think we have both above and below our northern border. Also, we coordinate and to create continuity with geriatric inpatient and outpatient providers. A couple of key partnerships that I want to point out and reflect on briefly. The first is EMS. If you look closely, and there's no need to, but if you look closely, you will see that on the side of that ambulance, it says the name of our hospital. It turns out in most cities in the US, most large cities, most ambulances are not run by hospitals, they're run by the city. Seattle Fire, Baltimore Fire Department. But in New York, individual hospitals run ambulance services. And our ambulance service is one of the largest, it may be the largest private ambulance service in the US. And we train them. They're trained by us. And so we've empowered our EMS, who evaluate patients in their home, and more on that in a moment, to bring patients preferentially to our ED and communicate their concerns. Again, we don't want them driving by emergency departments in patients with chest pain. But if the main concern is a mistreatment related concern, we think that the VEPT program can provide a higher standard of care. And so we want our EMS colleagues to come to us. Also, and again, you don't have adult protective services, but you have something similar. And let me explain what their frustration has been over the years. They arrive in a client's home, and at least in the States, we call them clients. So they arrive in a client's home and they find that the situation is immediately unsafe. And even though there isn't any specific procedures, most adult protective services workers will call 911 in the States or activate the emergency response system. And if you talk to experienced adult protective services workers, this process can be very frustrating. And the reason for that is that they call 911 and the older adult is placed in an ambulance and brought to an emergency department nearby. And then 4 to 8 hours go by. And the patient is seen by a doctor who has no information about what adult protective services was concerned about. They don't realize that adult protective services initiated EMS. They say to the patient, "Why are you here?" And the patient says, "I don't know. I feel fine." And then the patient is sent back to the unsafe situation. We thought we could make this better. And so, because our ambulance service has a private number that can dispatch them in an emergency response capacity, we have APS call us. So if they're concerned, they don't call 911, they call us. The police will come, our ambulance will come, but they'll bring them to our hospital. They'll page us while they're en route, and we, one of our team members, will meet the patient and APS worker who comes in the ambulance in the ER or the emerge department. And we will work together to figure out the safest plan. As you can imagine, Adult Protective Services really likes this program. We also slowed the program down and stopped it at the height of COVID and are just ramping it back up. We recognized that the last place that an older adult that didn't have a medical emergency belonged during COVID was the emergency department or hospital. And we also recognized that our emergency departments and hospitals were already overrun. But we are starting to build this program back up. I want to pause for a second, though. I added this slide this morning based on some conversations that I had with Ran earlier to highlight the role for EMS. Most of this presentation is about the role of the ED in hospital. But I wanted to pause for a few minutes, make sure I have a few minutes, I do, and talk a little bit about EMS. I remember when I first started as an ER doctor, as an ER attending after completing my residency, I saw a senior guy who had been one of my teachers, and he said, "Tony, I hear you're joining our faculty. That sounds like great news. What are you going to focus on?" And I said, "Well, I'm pretty interested in elder abuse. And is there something we can do about elder abuse?" And he said, "Gosh, that's a big problem. But we're ER doctors. It's not like we do home visits for these patients." And I thought for a minute, and then I recognized, you know what? Most of the patients that we see in the ER who are older adults, they just got a home visit. They got a home visit like 15 minutes ago. And so ultimately, EMS sees inside the home. They might be the only person that sees inside the home. And so they have an extraordinarily large role in the care of older adults, in my opinion. And they can play a big role. And we talked a little bit about community paramedicine and other options, and those are things that are outside the scope of this talk. But let's think about elder mistreatment. Wow. They really have a window, and here's a Hamilton bus. We call them buses in the States. I don't know what you call them, but we call them buses. Here's a bus from Hamilton, a photo of a bus from Hamilton. And we talked to EMS providers, and they said, yep, we commonly encounter this, and we recognize it. But we often don't discuss it with the ED. We often don't report it to the authorities. And they talk to us about barriers and strategies. They don't have really great protocols. They have their own time limitations. They don't get any follow-up. What about strategies for improvement? And these are things that you could think about working with your EMS colleagues. What about photographs showing the home environment? What about additional training? What about improved direct communication with social workers when they arrive to the emergency department? What about a dedicated location on forms to document their concerns? What about a reporting hotline? What about a system to provide feedback to EMS? And what about community paramedicine? One thing I'll say before I return to the main presentation is the perspective of an ER doc. And I hope that it's better in Canada, and I hope that it's getting better in the States. But I had an attending when I was training who used to say, I won't hear anything about this patient until you tell me what happened with the EMS. You need to bring me the EMS document. I don't do that with my residents, although I should. But realistically, if you read the EMS document, and many ER doctors provide care without doing so, you learn a lot that might change the kind of care you provide. And so EMS can play a critical role, and empowering them to play this role is really important. Now back to the presentation. No, I have one more slide on this, sorry. What are the things that they can look for? Well, here's a list that we use for concerns about the home environment. Utilities are not working correctly. Heating or cooling, wow, could that be important in Canada in the middle of the winter? Water, electricity, fecal or urine odor, empty refrigerator or no evidence of available food. I always tell when I train EMS, no visit to an older adult unless you're resuscitating them emergently does not involve opening the refrigerator door. Vermin infestation, extreme clutter or hoarding, absence of a smoke detector, presence of a fire hazard, expired or unmarked bottles of medication, or multiple bottles of a single medication. You'd be surprised how often a patient says, I take all these 5 medications, and you're like, well, 3 of these medications are the same thing. Or broken windows, which can be particularly important, of course, during a hot summer or a cold winter. Now, back to the main presentation. I want to be mindful of the time. It looks like I have 8 more minutes, which is perfect. When we first started, we got pilot funding for our program from a private foundation. And Alyssa, you can see her here, was providing informal advice after hospital admission. We decided we were only in the emerge department. We didn't have enough resources, only in the emerge department. But guess what? People kept asking us questions, and Alyssa tried to help. So then we were funded more recently by the New York State Office for Victim Services. There's an equivalent, or rather analogous, organization in Ontario. This comes from fines. And this is funds that are distributed to agencies that support crime victims, like domestic violence shelters, sexual assault, forensic examination programs in hospitals and in communities. And we were lucky enough to get this funding. And we used this funding to grow and fully fund our team, to respond to cases throughout the hospital, to follow patients throughout their hospitalization. We added an inpatient geriatrician to the team. We expanded our partnership with our adult protective services colleagues, and we developed a service with telehealth to expand to other emerge departments in New York. Here's our team, socially distanced at the height of COVID during our meeting. We're lucky enough to say that we were refunded, and we're expanding our program and strengthening and protocolizing our discharge follow-up program and offering consultation now to an outpatient geriatrics clinic. And we're funded through 2025. So we're very excited about that. We looked at our initial experience. We just published this a few months ago in the Journal of the American Geriatrics Society. So were we used a lot? We were. We provided care and consultation to 200 ED patients in the first 2 years. 62% of those were determined to have high or moderate suspicion for elder mistreatment. Among those that we were concerned about, 75% had a change in living situation or were discharged with new or additional home services. That just highlights how different the hospital is in its capabilities in a general way than the community. Of those, 14% were discharged to an elder abuse shelter, 39% to a different living or housing situation, and 22% with new or additional home services. Also, ED providers reported that the VEPT program made them more likely to consider and assess for elder abuse, that they recognize the value of the expertise and guidance that VEPT provided, and 94% reported believing there is merit in establishing VEPT program in other emergency departments. We're really excited about telehealth, and as I mentioned, we expanded to the Lower Manhattan Hospital, and we're now doing telehealth consultations at that institution as well. I know that even going at slow speed, I apologize, I know I was too fast for our ASL colleagues, but thank you to them very much. And are you going to remember any of this? Perhaps not. Here are 2 websites. This is a website with information about our program. And this website, elderabuseemergency.org, we built this website for emerge docs and folks that need information at 2 in the morning about what to do. And so hopefully these resources are helpful. We've written some academic manuscripts. We've presented our work as all over the country. We've gotten a little bit of recognition, which is certainly nice for us. This is the thing we're most proud is the wrong word, but this is the thing we're most excited about. We have been working with colleagues from the University of Colorado in Denver. It turns out that that institution is one of the world leaders in child abuse detection and response. In fact, they provide child abuse response for 6 US states. all in one hospital. But they provided no elder abuse response. And so with our assistance, they applied to the Colorado Office of Victims Programs and created their own team, VESPA, the Vulnerable Elder Services Protection and Advocacy Team, which is really exciting. So there was one team, now there are two, hopefully more in the future. And perhaps even most excitingly, this is us. This is us. We had a 2-day collaborative meeting with both teams hosted by us in New York City at our campus. And you can see we had several different presentations about radiographic findings, about different roles for different types of providers. Alyssa presented on ethics and some of what we've learned from the ethics committee. We presented a Lifetime Achievement Award to Risa Breckman, who I think many of you know, or at least know of. She is unequivocally a international leader in this field who recently retired, and I certainly consider a mentor and dear friend. And again, if this stuff is stuff that you're are less familiar with, we are in the process of working on a special issue of the Journal of Elder Abuse and Neglect, devoted entirely to different aspects of this work based on this 2-day meeting. So where does this leave you folks? Well, hopefully this has given you some thoughts. I frankly don't know much about Ontario, or certainly don't know as much as you folks do, but hopefully this has given you some ideas of the kind of things that you can do in your own community. There's funding available. There is an Ontario Office for Victims of Crime. I suspect that perhaps folks from that agency are even on this presentation. And just as in the States, they reinvest cash seized from criminals in local crime fighting projects. And at least in the States, sexual assault forensic nurses and support for crime victims in hospitals and in communities is typically already funded by this type of agency. Also, geriatric ED accreditation. Emerge departments throughout North America and the world are focused on obtaining expertise and an accreditation seal of approval in this area. And again, a mentor and friend and colleague of mine, Don Milady, here is leading the charge internationally, but he is based at the Sinai Hospital in Toronto. Also, there are recently, again, I should probably say 2.5 years ago, released trauma quality guidelines for trauma center recognition of child abuse, elder abuse, and intimate partner violence. And so again, these are US trauma centers. It's the American College of Emergency Physicians, but typically our Canadian colleagues in trauma surgery are often on the same page. And so there may be an opportunity for community-based providers to talk to these folks. We're here to help, and we want to be even more here to help. We'd be delighted to try to find a way to work on workshops with hospitals and emerge departments, if those are things that you think would be helpful. Medical folks, social work folks, nursing. We are developing, I apologize, not ready yet, but we are developing a toolkit for interested institutions with protocols and curricula and EHR documentation templates and advice about building a team and strategies to overcome issues. And so with that, I think 1 minute over, or 2 minutes over. Hopefully I've left at least 8 minutes for questions. You can see these are my crew members. They are 11 and 8. And I look forward to questions. I can see there are several things in the chat. Laura, I'll let you sort of choreograph what's next. I'm going to put myself on mute for a second, and I'm happy to respond to questions.
Yeah,
thanks
absolutely.
very much. And again, particularly thanks to our ASL interpreters. Hopefully I haven't been the worst of all the speakers for you folks today.
No, you've been very mindful. I've watched you watching our ASL interpreters to make sure that you weren't going too fast. So good job, Tony. I want to first take the opportunity to thank you for your enthusiasm around your program. What you guys are doing sounds truly inspirational for us to carbon copy up here in Ontario. So I'm getting a lot of feedback in the chat around thank you, inspiring. Somebody was asking if you could go back to the slide where you had some websites displayed. They were hoping that you could just cut and paste them and throw them in the chat box so our attendees could have access to them. Now, one question, we had a couple of capacity questions come through. So the first question that came through is, during the conference today, we've heard a lot about that reluctance of victims to disclose information due to that potential harm and safety or repercussions. Do victims have to say, get to say how much services become involved or whether to move forward? So I guess they're looking for that consent piece. Are you looking for full consent? You're muted,
I'm on
Tony.
mute.
Yeah.
I'm so glad you asked. And I warned Laura in advance that I like to answer questions in long ways, and there aren't a whole lot of topics that are more challenging than capacity. Ultimately, I'll give a couple of comments about capacity initially, and then I'll try to answer the question. Initially, I will say that the way that medical providers teach and learn capacity is that it is decision specific.
Mm-hmm.
And that older adults or anybody may have the capacity to make one decision and simultaneously not have the capacity to make another. And so ultimately, determining capacity can be very challenging. And colleagues and friends of mine at the New York City Elder Abuse Center and Weill Cornell Medicine have designed the interview for decisional abilities for, in the States, adult protective services workers to become trained in assessing for capacity to make different decisions. And this is something that is becoming a much more common thing for folks in the States to get trained on. Many, I'm not sort of at the very tip of knowing exactly where this is in dissemination, but many different US states have started training their adult protective services workers on this program. And I'll put this program, again, it's not a program that I'm involved in other than they're really nice people. But I will put this program, if I can find it, in the chat.
Thank you for your answer.
Laura, I'm not done. I haven't answered the question.
I had a feeling you might not be.
Again, I'm trying to be slow. So this is the interview for decisional abilities for APS, we call them in the States, but for community-based providers who may not be trained specifically in assessment for capacity. However, in my opinion, it depends on capacity. In my opinion, someone with capacity has the ability to refuse any and all services. After all, we are person-centered providers. That having been said, interestingly, in the United States, elder abuse is mandated reporting for medical providers in all but New York State. We're not excited about having mandatory reporting because we're not sure it works. And we're also not sure about folks that have capacity. So from my perspective, clinically, I don't work in a mandatory reporting environment. If I were to take shifts, and that's how we say it in Emerge, if I were to say take shifts in New Jersey, I would have to report. However, in the US, I would have to report. APS, or Adult Protective Services, would have to initiate an investigation. But typically, their assessment and their approach around services is also governed by capacity. And by the capacity, we say typically to refuse. Often in our world, the capacity question that we're asking, because remember I said it's decision specific, it's capacity to refuse services. And so again, I don't want to be subtle, and I apologize for the subtlety, Laura and everyone. But from my perspective, it is at least theoretically possible and likely practically realistic that after a psychiatric evaluation or whatever the structure is that you have, that one patient may be able to refuse some services, but not to refuse others. Again, I know that sounds counterintuitive, but it is the way we think about capacity, at least in theory. Hopefully that's helpful and doesn't create more questions and problems, but that's how I'd answer the question.
Absolutely. That's a great answer. And if it created more questions, I would encourage anyone to connect directly to Dr. Rosen to explore that conversation. So I'm just getting a couple comments from specifically Toronto Community Paramedicine program, how insightful this is. I know for Elder Abuse Prevention Ontario, we do a lot of training on around elder abuse response and intervention for community paramedicine programs across the province. So very important. And we really appreciate you taking the time to create new slides in talking about the role of EMS and how important that they are one of the last services that actually do those home visits, and so important to have eyes on in the home.
I couldn't agree more. And I know that it's time for us to move to the next thing. So I'll just say very briefly that I couldn't agree more. I'm a big believer in medics. I love medics. I think they do amazing work under really, really challenging circumstances. And I think that community paramedicine is the future for elder mistreatment, identification, intervention, and prevention. And I would add that from my perspective, in a fantasy future world, a community-based paramedic and a social worker working together inside the homes of these, again, I use the words advisedly, but high-risk older adults, I think has a lot of potential. With that, I'm going to sign off. Thanks, Laura.
Thanks, you.
Dan. Thanks, everybody. Have a great rest of your afternoon.
Take care. Thanks again.